Welcome to the Healing Grove podcast. I'm Dr. Kristen Ryman, an integrative holistic family physician, author of Life After Lyme, and host in this virtual space of learning, healing, and growing. I believe humans are like trees, and our physical limb is only one of many. Health on all limbs of the tree, emotional, conceptual, social, spiritual, is absolutely required for the whole tree that is you to be vibrantly well. I created the Healing Grove podcast as a place to showcase some of the world's best integrative and holistic medicine, to expose you to transformative tools and mindset shifts for all limbs of your tree. I hope you enjoy our conversation in the Healing Grove today as much as I enjoyed having it. Hello, my friend Meghan Tveit. How are you today?
Hello, Kristen Ryman. I am doing well. How are you?
Good. All right. Well, we're here because you are on a journey as a healer in training, and you've offered this time with us to share what's going on. And you just finished a rotation. So tell us what you just finished, and then let's get into how you're doing.
All right. So rotation number 3 in the books. I was just in my psychiatry rotation, which at my institution at George Washington, it's a 6-week long rotation. The first 3 weeks are on the floor. So at George Washington, the 6th floor is our psych unit. So anyone that has been admitted and is staying in the hospital for overnights, at least 3 to 5 nights, they come to the psych ward. And then the second 3 weeks, you're on a psych consult team. So this is a team that receives consults from anywhere else in the hospital, which means they can send you a message saying, my patient is having X psych problem or concern. And then we go as a team to evaluate the patient and provide recommendations for how their primary team can help address this psych issue.
So you're basically like the consult liaison for psychiatry. So can you give us an example of some of the things that patients are admitted for each of those 2-3 week periods? Like, what are the kinds of issues you're seeing as a med student?
Yeah, so George Washington is located right in the heart of DC. So we get all sorts we get a very wide range of patient presentations. And actually, that was something that I recognized at the end of my rotation as being very different from other people at different sites. So for example, we will get the mood disorders, so like bipolar disorder. We'll also get the psychotic disorders, so like schizophrenia. There's other forms like schizophreniform or schizoaffective disorder. And then we also have patients who are suffering from severe depression. If they're admitted, they're likely suicidal in some capacity or a harm to others. We have patients suffering from anxiety, depression, or maybe undiagnosed psychosis. So they've never been given a formal diagnosis, but they're hearing things that other people can't hear. They're seeing things that other people can't see. And then one of the most profound patients that I saw on the floor service, so that first 6 weeks where patients are admitted and stay the night and they're just there primarily for their psych concern, was actually an individual who is suffering from cannibalism. And that was something that they had never seen before. My attending had never seen this. And it was, it was just a very shocking experience to
hold on. When you say they were suffering from cannibalism, were they stressed by this, or were they perfectly fine to be, having cravings for human flesh?
So you're right. They were not suffering. They were perfectly fine. And they were doing this in a way where they would unearth caskets and
holy moly. Okay, just hold the phone, because I have never ever heard stories of anything like this. I mean, this is like Silence of the Lambs business.
It was wild. The whole unit was like,
what the heck?
Well, the craziest part too, right, is you're interviewing this guy, and we have a lot of patients who have delusions or hallucinations or these really fixed false beliefs that they are rooted in. So a lot of the times you're going through the story and you're acknowledging, you're validating, but you know that there's an element of psychosis tied to the story. So at first, obviously, that was the case when we were interviewing this patient. Like, okay, this can't really be true. Until we decided to just, do some due diligence and do some research on what he's saying, because he was providing a lot of high level detail. And we came to find that what he was saying was actually true.
So if this is not, so maybe we can talk about ego dystonic, ego syntonic. Have you learned the words in psych?
Yeah.
So ego dystonic meaning like the person who's experiencing a mind that's gone astray or awry, right? Like what we would call mental illness, is not happy about it if it's ego dystonic, right?
Correct.
Yep. Like their ego is sort of standing aside and going, okay, this is happening in my brain. I'm not okay with it. This isn't me, right?
It's not aligned with their goals. Yep.
And an ego syntonic situation is where I'm eating my fellow humans and I'm okay with that. Okay, this seems more like something that would be an issue for like the criminal justice system as opposed to a psych ward. So tell me, so
he was, once this was proven true, he was immediately transferred to a higher level secure psych institution that has, for like people that are involved with criminal law. So this patient was only on our ward for one day, but it was still like an uproar because obviously no one had, my attendings who have been in this role for 40 years, even maybe 30 years, have not experienced a patient like this before. So
wow. So I guess then it's sort of a journey of discovery still, like what the ultimate diagnosis was, or whether even there was one, because maybe he was in the wrong place, needed a jail or a courtroom as opposed to, wow. So, okay. So let's just talk about what it was like for you being in the room with that person. You obviously weren't alone with that person.
We don't interview any of our patients alone ever as medical students. Not only for our safety, but also for the safety of our patients. We are not trained in medical school. One underlying thing that I've realized throughout my psych rotation is psych and the mind is an entirely different form of medicine than what we learned in medical school. So we are not trained enough to provide one-on-one care for these patients. And also it's a safety thing. So no, we never interview patients by ourselves.
So what is your role as a medical student in this example, for example? So this guy was on your service for a short minute. What was your role supposed to be?
So I personally was not assigned to him, but I was not involved directly in his care, but I was there for the interview and things. Mm-hmm. But when I am directly assigned to a patient, so I show up in the morning and I have, my name with who I am supposed to see, I go with my attending and I am the driver of the interview. So there's a very systematic approach to a psych interview, depending on the chief complaint or whatever the patient is coming in with and their concerns for. A lot of our patients that are admitted with some sort of suicidal ideation, obviously you're wanting to address that. If we started new medications, we're seeing how did this dose feel overnight? Did you notice any side effects? So there's a very systematic approach. So, and we would lead that as a medical student and the attending would observe. And then obviously if we had gaps or if there were things that they needed to kind of fill in, then they would do so. But I did feel like a driver in that sense. And, I would write the note and do all that stuff. But I also didn't feel like I was providing very much care, if that makes sense. That was the hard part.
Like on the team, who is responsible for providing care and what does that look like in a psych rotation?
It really just looks like medications. Unfortunately, at this level of severity, what I observed was titration and dose changes in different medications. And there are a lot of antipsychotics with different side effect profiles, respond differently to different ethnicities, different types of people. So it's really being able, the therapy and the approach to a, inpatient psych, or an inpatient psych patient is, how can I methodically approach their medication regimen to minimize symptoms and maximize well-being, is what I've realized.
Mm-hmm. Yeah. And I think that's that's something that a lot of people don't understand about the hospital. And it's, I don't think anywhere more sort of clear than it is on psych, that it's really just a place to kind of stabilize people and get them to their primary care. What percent of people would you say are just like, when they come in, actually have a primary care or a primary therapist, I guess, in the community?
So we had amazing social workers, and I think that's honestly what the patients coming into, because patients were only staying minimum 3 nights, maximum 7 nights. So it wasn't like a long-term stay. So the social workers were really awesome and would set up these patients with, their next visit, psychiatrist if they didn't have one already. But what I've realized, the main problem is a lot of these individuals don't recognize their condition as an illness. They don't actually think that there's anything wrong. They have this they're egocentric in a way that they're thinking what they're doing is normal and everyone else is crazy. And with that, the idea of taking medications and going to follow-up appointments is almost a non-starter sometimes.
Did you have any moments where you were with a patient and really just kind of vibing with their story in such a way where you were kind of like, actually, maybe this is the sane person and maybe the rest of the world is kind of crazy?
I had a couple of those. What was the most interesting is there were patients who were like very highly educated. And I had a patient who was a former law student and ended up dropping out and started hearing voices. And there's a lot of logic to what he was saying, and it made sense. But he's saying, people are out to get me. The FBI is involved. I can hear them talking to me to kill myself, to do this, this, and this. And it was this pull of like, oh my gosh, that there has to be there's this level of psychosis going on, but this person is so aware of their condition and they're so present and able to articulate what's going on. Am I making assumptions when I'm wrong? And we had a couple patients where it was their first break psychosis. And for me, that was always a really challenging moment of like, is this real? How can we reverse this? What is going on here?
So how, we talked a lot when you were on surgery about sort of this feeling of like, it feels really good to be able to do a thing and fix a person. And then you had a moment where, there was a kid who didn't get fixed, or he came back still needing help. And that was really jarring. What was your experience with your relationship to medicine, psychiatric medicine in this case, throughout this rotation?
To be honest, I struggled so much. I really didn't know how I was helping. I felt like my brain works in this way where I want to identify this problem, and then I want to work collectively to think through a solution and a plan, and then execute and see results. And with mental illness, nothing works that fast, first of all. And second of all, it's not a linear trajectory of improvement. And oftentimes there's a lot of failed attempts before you even start to see signs of potential improvement. So for me, it was just really challenging to come in every day and see either no improvement or to see regression, or to discharge a patient who was not well. And that was there was never a time, never a patient that I discharged that I was like, okay, you know, they're healed. And again, going back to the surgery thing, I think I have this notion that medicine, as healers, our role is to change the trajectory, and then once you've done that, it's an upward trajectory from there. And I'm just continuously facing these battles where either I don't feel like I'm able to change that trajectory, or I did, but then I see it revert right back down to what got them into the hospital. And that's challenging for me. That's definitely something I'm recognizing as a struggle.
Mm-hmm. What do you feel like was missing, if anything? Were you able to sort of I wish there could be more of this or less of this in this system for these people?
Yeah, I think that I wish there was more of a therapy component. So psychiatry, from what I did on this rotation, felt very medication focused, minimizing side effects, maximizing your well-being, and adjusting based on experience. But I think because a lot of what people are experiencing are tied to something much more deeply rooted than what's on the surface. I think that therapy becomes so critical. And it's interesting. I don't know if in your training there were like inpatient in the hospital therapists that could go bedside. But we
Yeah, they
didn't have
were
them.
called medical students.
Yeah. Well, that's what I ended up feeling like. And I was like, okay, I have more time to spend with these patients, but I also didn't feel trained or equipped to handle that. So it was this, yeah, I hear you on that.
Yeah, I mean, so and I'm curious about the 7-day maximum, if that's like a hospital policy or if that's just an average, but there were some people who were, an inpatient staying, weeks and weeks. Although the goal is always to get them out as quickly as they're stabilized, but at least at Stanford, there were inpatient groups. They had daily groups to go to, especially, when you get admitted for psychiatric reasons, it's usually because you're unstable, you're a danger to yourself or a danger to others, right? And they do have groups typically at most places. I'd be surprised if there were none at
We
George.
have groups.
Yeah.
We have groups.
But they maybe met the psychiatrist once a day or every other day to kind of manage, but there's not a lot of, hold on, sneezing coming. No, I scared it off. There's not even a goal of connecting you to a therapist who you'll work with long term, because those people generally stay in the hospital setting. They don't have outpatient followings, and so the social worker's working hard to set you up with therapy after you leave. What can be very tricky is a lot of people go through this inpatient, which is very intense. You're there 24 hours, often you're monitored 24 hours. You're discharged to the next level down of care, or the next level of acuity, which is called partial hospitalization program in many cases. And in a partial hospitalization program, you're going 5 days a week for 8-hour days for a lot of group therapy. And you'll see a psychiatrist once every few days or whatever, but it's mostly therapy, but it's not your final therapist. So you have a therapist or a psychiatrist and maybe a therapist in the hospital. You get to step down into partial hospiitalization. You have a new set of therapists. And the next level down, which is intensive outpatient or IOP, which is maybe 3-hour days a week or something. That's going to be a totally new set of people too, in many cases. So maybe 5 months after your acute issue that caused the initial, hospitalization, you're now out in the community again. You're discharged from IOP, and now you're like, okay, where's my therapist? And that's when you start with a community therapist and a psychiatrist, usually, which you may never have met through this whole long period. It's a very disjointed experience for people.
Yes. And I mean, from my own experience in therapy, you have to give so much to allow this other human being to know who you are. And so imagine having to do that and then do that and then do that. And I think it's exhausting. And then at some point people just give up because it's like, okay, well, this person started helping me and now I have to move on to this next person. And it's going to take another X amount of days for me to build that rapport. And it's hard. And a lot of people also don't have the access to care or the understanding of the importance of therapy. So I wish, and I do recognize that groups are really beneficial for patients, and it keeps them also just busy and doing things while they're admitted, because it is, I mean, it's a really boring place to be if there's not things going on. And but the individual element, like figuring out what's going on for you at a deeper level, I feel like requires one-on-one attention.
Yeah.
And there isn't really that in the hospital setting. I agree with you that as you kind of de-escalate, that you get more of that. But
So I'm also curious to know whether there's any component in your education right now around the role that inflammation plays in mental illness. Did anyone talk about that?
Zero, none,
Okay.
none.
So
No.
nothing's changed. That's discouraging, because it's so clear in the literature that depression has an inflammatory component, and people who don't address that or aren't talking about that, I'm sure they weren't talking about diet. I'm sure they weren't talking about inflammatory foods or people who live in mold or people who have
No labs.
Yeah.
On the psych ward.
Yeah. So you and I talk about this kind of stuff all the time. We've been talking about it for 3 or 4 years, and I've sent you a bunch of podcast episodes from Dr. Roger McFillin, who I just interviewed in Grove a couple months ago. Did you listen to any of those? And if you did, I'm curious to know kind of how that framework kind of resonates or, jostles around in your brain when you're walking through your psych rotation.
Totally. I mean, yes, I do listen to the things you send me, of course. Maybe not
you have to say
everything,
that anyway.
but no, but of course it does. It really does. When I think of all the inflammatory markers, especially when talking about illnesses that are maybe not easily identifiable from the external. So even thinking of something like Lyme, which I don't think I heard that word once on the whole unit in my 6 weeks. I did not hear that. I hear any consideration of that, just as a reference. But I don't feel like I have any space to bring up this presumed idea of, oh, this patient is unhoused and they have no clean clothing. They probably don't have access to any nutrient-rich foods. They're very malnourished. They probably have some sort of inflammation going on if we did a couple labs. If I said that, I think I would have been looked at like I have 3 eyes.
You do. You have the third eye that's wide open.
No, but seriously, it's really, it's hard to describe, because I do think we don't think outside the box as much as we can when it comes to mental health.
So what percentage of you is having these thoughts, even if you're not speaking them? Like, do you see them at home? Do you kind of, I mean, it's hard, right? You have to,
it's really hard.
Compartmentalization we talked about before. And to some degree that's required. If you're not going to feel comfortable bringing things up, or if it's not going to make a difference, or if you're going to get laughed off the rotation, you make decisions, right? To compartmentalize some information that you may have.
Yeah. I would say 80% of me thinks about it from my own body and my family and my loved ones, and how, what we eat, how we live, what we do impacts our mental health. And I can vocalize that confidently. I would say about 10% of me in the hospital setting feels willing and able to go there. And I recognize that as a problem. However, I am just the lowest little thing on the totem pole, and maybe I need to be okay with just voicing my actual concerns. But it's hard. It's very hard.
Yeah. What I feel like maybe that my math is off. Was there like another 10% that we didn't get a check-in on? What's the
Well,
other?
I was more so just saying, like, I think the percentage was confusing when you asked it, but I think about it in my own life a lot. Over 50% of the time, I'm thinking about how, my decisions are affecting my own health and the health of my family and my friends. But in the hospital setting, because it's not the norm, I don't think about those things as much.
Right. So you leave that part of yourself kind of at the door so you can,
Mm-hmm.
yeah, that's that makes a lot of sense. It's like there's a time and a place, like there's the whole read the room moment, right? I remember bringing up something about hypnosis on my psych rotation about a girl who I don't know, she was like 14 or 15 and she had, was classically called conversion disorder.
Mm-hmm.
They still call it conversion disorder.
Yes, they do. Yep.
Yeah.
Neurologic dysfunction.
Yeah. Yeah. Basically like just sort of like would check out and like be a different person for a while and then like come back in.
Yeah.
And at the time I was taking I had my consult liaison who I'd done prior to my psych, floor rotation, was this really interesting guy who used to be a Catholic priest and told us stories about doing exorcisms. And he'd also knew hypnosis. He'd like been trained in hypnosis. And I was like, you have to teach us. You have to teach the Stanford medical students how to do hypnosis. And he was like, I'll do it. So we put together an elective. And so, yeah, so we're all sitting around learning hypnosis for, 6 months in our own time after hours. And that was when I did my rotation. And I was like, we have to get him in here to do hypnosis on her? And they're like, well, we can't get him in here. She doesn't have time. He doesn't have time for that, but you can do hypnosis. And I was like, well, I just learned it like last week. Yeah.
Did you do it?
I did do it.
Did it work?
And yeah. And she had not only conversion disorder, she also had this like phantom limb pain, the whole like, neurogenic pain and
restless leg. Yeah.
Yeah. Reflex sympathetic dystrophy, where she was feeling pain from an injury she'd had. And that was sort of leading to like it was all wrapped up with the conversion disorder, but I worked on her phantom limb pain and it went away during the session.
Yeah.
Not to say it went away forever, but like there was stuff that you could do, right? And
Yeah.
all the residents were rolling their eyes. And it's only because the other attending who had been the priest had such kind of clout that the attending didn't roll her eyes. But yeah, it was you pick those moments, right? Where you say, I'm going to trot out this thing because I'm confident that it's not going to hurt or kill anybody and it's potentially very cool, and screw it, I'm just going to bring it to the attention of the team, and maybe they say no, maybe they say yes. And you're right, you don't always have power to or the authority rather to make those calls, but sometimes they let you do stuff.
That is empowering. And I do recognize that I need to be able to just say it. If I'm feeling it, say it. If they don't agree, who cares? And have you heard of EMDR?
Oh yeah.
So I did it as just they were kind of teaching us about it as a therapy tool. And one of my attendings just asked, do you want to just do a round of it to understand kind of what it is? And for people that don't know, the one that I did, the theory behind EMDR is that if you have some sort of trauma or some sort of event that you in your lifetime that has been causing distress in some way, maybe it's intrusive thoughts, maybe it's depression, maybe it's anxiety, but it's tied to some core memory. By bringing that memory to the forefront of your mind and using these rapid eye movements, so ours was in the form of a laser on a screen. So you have this laser. The idea is that you can rewire the circuits of your brain that surround that memory through the rapid eye movement. So if you think about REM sleep, that's when a lot of your memory processing occurs. So what it's emulating is this rapid eye movement to then associate this traumatic memory that you may have as something a little bit less traumatic. So it's basically allowing you to try to process this event through rapid eye movement. And there's not like a clear-cut science, but there's evidence to its efficacy, and it's fascinating to me. I don't know if, Kristen, you've heard more about it or tried it or done
Well,
it.
it's the foundation of the WHEE tapping that I taught you.
Yes.
I mean, WHEE
Yes, it
stands for
is.
holistic hybrid of EFT and EMDR. So it's essentially the same concept. It's not as, EMDR can be very intense, probably because you're like back and forth with your eyes, can be very dizzying, and it can really allow you to release some cathartic stuff. So they recommend that that's always done with a therapist present.
Right.
EFT does not require a therapist present, but often requires some, being focused on where the points are, because you're moving through different acupuncture points for EFT. WHEE is just back and forth tapping, but it's all the same stuff. I just find WHEE to be the most portable and kind of accessible and easy one to teach people and let them do themselves. But it's the same concept, as you're doing something back and forth, crossing the midline in the brain, triggers some release mechanism so that the body and the brain that are holding on to these thoughts or feelings or memories that are traumatic can kind of release them.
Yeah. It's fascinating. So the WHEE stands for what?
Holistic hybrid. So holistic with a W,
Right.
of EFT, which is the tapping on acupuncture meridians and doing the affirmations, and EMDR. So it's basically a guy named Dan Benor, who was a psychiatrist and did EMDR and learned EFT, kind of simplified them both into, which is essentially back and forth tapping as you go through even though I feel blah, 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 all the bad stuff, I still blah, 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 all the good stuff while you're stimulating back and forth somehow.
Yeah.
Does the same
Fascinating.
thing.
Yeah. And it is
can't
portable.
believe,
You're right.
So how was it for you?
It was actually fascinating, because I feel like even in this short, a lot of people, it takes, it's many cycles. You're doing it with a therapist over a longitudinal period. But even in this short instance, I probably didn't even go as long as you would do a typical session. I truly felt a release. And they had me, ground myself in one core memory that's distressing. And from there, evaluating how I felt about that memory even now is improved. There's definitely a component of a release there. So I do believe in its efficacy, and I don't know. I think it's something that is new. It's up and coming, and I think it has serious potential for people.
Yeah, it's huge. I love that they taught you that. I mean, I love that you just taught us that, that you just shared that with this whole audience listening to you, because it deserves more attention and people need to be aware of it. And I hope people will also look into WHEE, which is, I think, much more portable. You don't need a therapist to do it, and they all work. They're all amazing. So how do you feel like you have changed over the last 4 months?
I feel like I'm at this midpoint of rotations where people are starting to figure out what they want to be and what they want to do and what they want to apply to residency as.
Yeah.
And I feel very lost. I feel very unsure. I don't know what I want to be or what I want to do. So I think what I've learned about myself is that I love medicine. This is all very exciting to me, but I am having a hard time figuring out where my calling, or where I am supposed to serve patients best. And I think it does make me nervous, and there's a level of pressure to decide and know and be convicted. And everyone talks about this like moment, and I don't know if I'm supposed to have that, if I will have that, or if I just need to release and let it happen. But I don't think psychiatry is for me. I really valued this last 6 weeks. I think I got to see patients that I will never see in my future clinical practice, and I'm grateful for that. And I learned a lot. But I think for reasons that I said before, where I don't feel like I'm seeing that output, that satisfaction of, healing or improvement is challenging for me. And that's why I don't think this is the route, but I don't know what is the route yet.
That's honest. I'm wondering if you got any glimpses, either on your psych rotations or beforehand, of outpatient therapists who are less doing the med management and more doing psychotherapy.
Yes, a little bit. We only got to spend a couple days in the outpatient setting, just because it is a little more intimate. It's hard to be like a third party in the room where someone's going through deep therapy and you're just kind of staring at them. A lot of people don't really like that, and it inhibits the relationship between the therapist and the patient. So I didn't have a great deal of experience in that setting. However, I have this level of intensity to me, and like I like to use my hands and I like to go, go, go. I don't know if I'm built for sitting and providing that level of therapy. I don't know, but I don't believe that is where I can be my best.
Mm-hmm. Well, especially if you're imagining a job where you're sitting with your computer in an office with a patient across from you, as opposed to like taking them on a walk or building a habitat for humanity while you're doing therapy. I mean,
that would be awesome.
I fantasize about these all the time because that's kind of the way I want to practice medicine, and I'm halfway there. But, I think this is the trouble with our system. Our training system doesn't show us all the little glimpses of people who are doing it in really different and potentially more nourishing ways for the doctors.
Yeah.
As well as
one, that's so funny you say that, because one thing that I found that I was very intrigued by and I felt like I would really like was for people that have specific phobias. So whether it be bridges or heights or spiders or whatever, there's desensitization, exposure therapy, where or maybe even people are afraid of being in like grocery stores, or agoraphobia, it's called, being in public spaces where you don't have immediate escape. As the therapist practicing exposure therapy or desensitization therapy, you get to work with them through these potentially traumatizing or scary experiences that they've had, and actually go and spend time in these locations, exposing them to these fearful environments, but in a way that is very constructive and healthy, obviously not just like throwing them into it. But to me, like the idea of being so active with it actually was very intriguing.
Yeah. Well, I mean, don't let go of that. I think you're so good with people, and you're so intuitive, and you have such a big heart. And I think I can't really imagine you in any capacity where you don't get to share all those things with people.
Mm-hmm.
So I wouldn't give up the possibility that there's a way in which you can weave all that in, whether it's psych or something else,
Yeah. Yeah, I agree. And I mean, to look ahead, I have my OBGYN rotation next. And there's a level that I think when I think about, perinatal health and women going through postpartum depression or infertility and having to deal with the anxiety and sadness that comes with that, I think there is a level that excites me. Those conversations that I can, still be able to kind of take on that role. That's something that I'm interested to see how it all plays out. So OBGYN is next, and I do think that that's going to hopefully be eye-opening for me. We'll see.
Yeah, I think you'll love it. Well, what else needs to be said about, as we close the door on the psych rotation, what haven't we kind of reflected upon that you want to have a little time capsule of for yourself?
The one last thing that I feel like I I gained and I found very different from anything I've done before is the idea of being a consult and having every other medical team, come to you when they think that their patient has a psych problem.
Mm.
What I realized is that people are scared to address something that isn't in their realm of expertise. So like if they're the heart, we have like the heart team, right? So their whole focus is your cardiovascular system. And when there's any form of depression or anxiety or panic, we had a patient that was having like panic attacks. It's almost like a hands off immediately needs to see a psych patient or a psych consult. And I think there's a need for that too. But one thing I just realized is there was a lack of holistic training about how to support them initially before needing this consult. It was just like, I'm just going to lean on you when I need it because I don't have the tools. But I think we can have the tools if we at least try a little bit. And it just kept happening. It happened a lot with capacity. So if a team felt like their patient did not have the capacity to make medical decisions for themselves, they would consult the psych team. And all it takes to assess capacity is to understand if the patient can reiterate their medical condition, their treatment options, what happens if they don't go through treatment. But I think with the fear of or I don't know what it is, but people won't go there, take that extra step to ask those questions. I know they're harder questions a lot of the times, and it was immediate consult. So we just got some silly consults where I was always like, I feel like you could have asked this question yourself, but I don't know if there's a level of fear or lack of understanding or education on how to address those problems, which I don't know.
I don't think it's a lack of education. I mean, everyone I think it's important to realize that at this level in your training, you have been recently reminded of things in a broad variety of specialties, right? Studying for your steps, going through your rotations,
right.
all fresh and new. And it's like new for you. And it's stuff that many of these doctors who are deep into their siloed specialty haven't thought about in a long time. Like maybe the cardiologist hasn't done a mini mental status exam in 25 years and you did one on Thursday, right? Mm-hmm. So, or on your psych rotation. So it's part of it's that they don't want to have to do something that's not as perfect as it could be or would have been if they were in that field. Mm-hmm. I think another piece of it is just time, I don't know if it's still this way, but I don't remember having a whole lot of free time, in my rotations. And so, what kind of where your lane is, and you have to get all your ducks in a row in your lane, and you don't want to have to necessarily go out of your lane to do someone else's lane because you really don't have time enough for your own ducks. Mm-hmm. That's a piece of it too.
Totally.
Yeah. Totally. But I'm just going to put out there that you're sounding a little bit like a family doctor.
You think?
Well, I mean, just call it when you see it. You're talking about like, can't we all like do some of these things in these different specialties and be like a little bit more generalist and holistic? I mean, holistic and generalist is basically the same thing. You're looking at the whole person, and you're bringing in all your tools. And so I'm just putting it out there. When are you doing family medicine?
After OBGYN, I do for my family medicine.
Okay.
Yep.
Cool. Well, it's just needed to say it for the record.
Keep it on the record. This is all for the record. We'll see what happens. It's a journey, and that's why we're here.
All right. So what's next on your journey?
Well, I do get some elective time. So I get 2 weeks of elective, and I'm using this time to have my lovely family visit DC for the first time as a group.
Wow, cool.
They get in a couple days. I'm so excited. And I'm doing a lot of research right now just to get I need publications and get the residency application tip-top shape. So yeah, that's where I'm at.
Cool. So you don't have any kind of place to show up every day for the next 2 weeks. You're just on your own schedule. That's such a gift.
It's a huge gift. It's a huge gift. I'm very much looking forward to it.
And has fall come to DC yet?
Has who?
Fall.
Oh, fall. They said Paul. Yes, last week the week before last, we had total fall arrival, and then we had this crazy summer boom, and then this week it's looking like it's fall again. So I'm very excited. I like
Nice.
fall.
Yeah.
Yeah.
Good. Well, that's a beautiful time to have your family out. I'm so excited for you. Tell them hi.
I will.
I
I
said hi,
will.
say hi to them.
Yes.
And yeah, and we'll stay in touch. So OB's next, and then family, and then you're going to be applying for
Well, then I have to do internal med.
internal
And
med.
then,
Okay. And when do you have to put your list in for sub internships?
so I need to probably have made that decision by January, end of December, start of
Yeah.
the new year.
Okay. Cool. Well, listen,
Yep.
I'm aware that you are in your weekend now, and I want to let you get back to it. But this has been great. Thank you so much, Meghan, for this conversation, for keeping us posted on your journey. Is there anything you want to tell your future self? You've started looking back over these, I hear, already.
Yeah,
have you
I listened
changed?
to the surgery one.
Have you seen yourself change?
What honestly I was shocked by is I feel like when we reflect on memories, sometimes we don't go to the ones that are the best, the most positive. I think when I reflect on surgeries, I have this like, oh my gosh, I was working so many hours. It was so stressful. And then I listened to myself on that podcast and I was like, I am so happy. Like I am exhausted, but this is so energizing. And I've been able to help so many patients. And I was like, whoa, I did feel that way. I forgot that that's how I felt. And so it was very eye-opening for me because I feel like I resort to these sometimes what we hold on to are not the most positive memories of an event. And so it was nice for me to be like, oh wait, that wasn't an awful experience. That was actually a really, really valuable experience.
Cool.
Yeah.
I'm glad this can do that for you. That's great.
Hmm.
All right, sweetie. Have a great rest of your weekend, and I will see you in a month for our next installation.
Sounds good. See you later.
I hope you enjoyed this episode of the Healing Grove podcast. If you liked it, please be sure to like and subscribe. And if you want to deepen your experience further, consider grabbing a copy of the Healing Grove Playbook. With journal prompts for this podcast and 41 others, it's the perfect place to record your learnings, keep track of the tools you explore, and reflect on your own experience. Finally, it's important to mention that even though I am a doctor, nothing you hear on this podcast, whether from myself or my guests, constitutes medical advice. Any intervention you try should always be discussed with and supervised by a trusted member of your own healing team. Thanks for listening, and see you next time in the Healing Grove.